Megamind.
Thank you very much, everybody, for coming here today. I'd like to thank Dr. Park and Megagen for having me here and inviting me. And I really, really appreciate the opportunity to be able to speak in front of you all. Okay, there we go. My name's Dr. Dean Licenblat, and I'm from Sydney, Australia. I did my dentistry in Sydney. I did a Master of Science at Goethe University with MOI. I've got a Bachelor of Science and Honours in Microbiology and Biochemistry. And as I saw before, I was the first Australian diplomat of the ABOI. So my lecture today, or my talk today, is about the modern-day biomimetic approach to the single immediate implant, rather. So the patient I'd like to introduce is a male. His medical history was that he is type 2 diabetic. He has no known drug allergies, and he takes over-the-counter medication for pain relief for his lower back. Dental history, had a number of implants placed overseas in Thailand, which have been successful to date, and he's had a number of crown and bridge procedures and restorative procedures done on posterior teeth, and they were done in other offices. His social history, he's a non-smoker, he's a non-drinker or social drinker, and he declines any illicit drug use. He is retired, he's in a stable relationship, and he's Greek, and he eats predominantly a European diet, which is high in nuts and seeds. So on examination, the patient presented as a referral. He had a decoronated 3-5, or a lower left second premolar. And the tooth was unrestorable without doing crown lengthening, complex root canal, post-core crown, etc. The patient denied wanting to do this. And when he presented, there was no pain, no discomfort, no infection, and the patient was seeking implant therapy on the basis that he'd already had a lot of successful implants before. He declined having a bridge, he declined having a removable denture, and he declined doing no treatment at all. So this was the pre-op evaluation, and this is how the patient presented to my office. This was the OPG, and you can see that the tooth is broken down at the gingival margin. You can see he's had a number of restorative work done, and you can see he's no stranger to implantology. My surgical plan here was to do a partial extraction therapy and include the blue diamond implant, which has just arrived in Australia. This is my surgical plan. You can see that the implant was designed to be placed lingually, and this is what it looked like from the OPG. So on our pre-op evaluation, you can see here, this is the outline of the tooth, and the crosshairs is exactly where I plan to start doing my initial sectioning of the root. The blue line denotes where that soft tissue and the hard tissue has resorbed to. And this is the reason why I elected to do a partial extraction therapy here, because this patient is quite prone to having resorption. The kit that I used to do my partial extraction therapy was the Megagen partial extraction therapy kit by Howard Gluckman. And you can see here in the first instance, I used the lance drill to length to widen the root canal, and then following this, I used the Lindemann drill to section the tooth mesial to distal, all the way down to the apex. And that was according to the protocol as outlined in the literature at the bottom. The lingual fragment of the tooth was removed, and following this, we used the long diamond round burr to clear out the apex and remove all the root canal content. From there, the shaping of the shield was done, and this was finished with the inverted cone. As you can see here, based on my initial presentation, where I wanted to go horizontally and make my root section, I was off by about 9 degrees. At the end of the day, this will not create any complications for me, but it was just not exactly where I originally wanted it to be. Once I'd done that and shaped the shield to where I wanted it to be, I used the final shaper to reduce the shield down to the level of the bone. Now, I know in some of the literature suggests that you can leave the shield about 1 millimeter above the crest of bone. I don't do that, and that's not the procedure or the protocol that I follow. I like to do the shield down to the level of the bone, so that way it minimizes my chance of having an internal exposure and creates more room for the soft tissue. Once that was done, I created that internal chamfer again to create more room for the bone substitute material and for the soft tissue, and again, reduce the risk of having an internal exposure. This is what the shield looked like when it was completed. Now, prior to implant placement, there we go, I essentially made sure that the shield, there was no fractures, then there was no movement, which is very, very important for the success of that. I also ensured that all the root canal content had been adequately removed, and then I flushed what was left with an antibiotic solution to remove all the debris and decrease the probability of having any infection. The shield was prepared equicrestally, as I described before, and it was prepared to essentially essentially I prepared a freehand osteotomy such that the implant head would sit 0.5 millimeter above the prepared chamfer, such that it would allow for the proper healing of the biomaterial and of the soft tissue, and not put too much pressure on the shield. And this is in accordance with the current literature as well. The implant that I selected had a deep conical connection, and this is why I decided to choose the blue diamond implant. It has a very deep conical connection, and that suits my workflow, and it suits the sort of procedure that I'm doing. Again, the implant that I placed was a MegaGen blue diamond that was 4 millimeters in diameter and 10 millimeters long. Obviously, I had other options in which to place this, but there was very, very limited stock available in Australia at the time. Blue diamond has really only been in Australia for about 15, 16 days, something like that. Or maybe a little bit longer. Anyway, the jump gap was grafted with BioOS collagen, and if you look at the literature, I know that you can see here that it has been rehydrated with Emdogain. Now, I know the literature suggests that this is an unnecessary step. It was a step that was done originally with Herzler's proof of principle in dog, but the reason I chose to do it in this particular case is that when you have a look at when the osteotomy was prepared, the socket was not bleeding tremendously much. Further to this, the patient is type 2 diabetic, and I felt that in this case, I wanted to give this patient every single possibility of having no infection and no problem. And those of you who have used Emdogain will know that as soon as that touches tissue or bone, it creates a significant bleeding response. And that's exactly what I wanted. Now you can see the implant has been placed and the jump gap has been filled, and you can see that there's quite a bit of blood that is associated with that biomaterial now, and that's exactly what I wanted. After this, what I decided to do was I had enough primary stability to be able to put in a healing abutment or to be able to do an immediate restoration, but what I decided to do was do a custom healing abutment, and I did this because he was diabetic and I don't particularly trust this patient. He has a high occlusion. You can see on his premolars and some of his other teeth, he's got a lot of restorations and he's got wear facets as well. So what I did here was I took this amniotic chorion membrane, which is bio-exclude, and I use this as a poncho in the poncho technique. And I did this because it's very, very, very thin, and it's very good at encouraging soft tissue to close. Here's the custom healing abutment that was done, with an exaggerated S-curve to create enough space that there is no pressure on the shield, and that it allows good healing of the soft tissue and good healing of the bone substitute material, but it also creates a socket seal, not unlike what was described with the dual zone therapy by Tarnow et al. This is the initial phase of this treatment is completed. You can see a little bit of that bio-exclude sticking out, just like I described with the poncho technique, and this is how it was at the end of the surgery. This is the immediately post-op periapical radiograph. And this is how the patient presented 2 weeks later for review. As you can see here, you can see that the wear facets are on the teeth there, so you know that he does have a heavy occlusion, you know that there is potentially some parafunction, and that's again why I decided to do a custom healing abutment as opposed to an immediate restoration. You will also note that previous to this,
and before all implants, I ensure that my patients have hygiene and go through the hygiene department of my practice and ensure that there's no perio and all that sort of stuff. But you can see when the patient presented here for follow-up, there's marked plaque on the adjacent teeth. So once I saw this, I made sure that he went through hygiene department again to have oral hygiene, spoken about again and reinforced. Here's the situation at 2 weeks. Again, you can see there's a marked plaque on those adjacent teeth, which I was not very happy about. And you can actually see there's plaque on the custom healing abutment as well. So he had to be educated about that. And that's what it was like at 2 weeks. So that essentially brings us to the end of that particular case. Now, Megagen is only relatively new in Australia. So what I'd like to show you is the reason why I like doing partial extraction therapies, and I do it for every single case that I can, including posteriors, is because of the soft tissue and the architecture that we're able to maintain. So that case is to be continued. Now, I've done a lot of cases with Straumann, but I've now moved to Megagen. In fact, my whole practice has moved to Megagen. So this is a case that I wanted to show you about. This is what I'm expecting to see. Partial extraction is not a one-off. It's not something that can only be done by one person. This is something that's repeatable. So you can see here there is another case where the patient came in with a decoronated canine. The tooth was sectioned, the partial extraction was done, the shield was prepared, the implant was placed, the jump gap was grafted. So now I'm going to show that it is beyond proof of principle, and again, you'll hear that from a lot of other people hopefully this week. Now you can see here I put a temporary cylinder, I've created that custom abutment, and made sure that I've got the S-curve and the poncho all as it is described in the literature. And you can see that after 3 months, this is exactly what we're seeing, and I expect to see this with all partial extraction therapies. The maintenance of the hard tissue architecture, the maintenance of the soft tissue profile, these are the things that I'm starting to expect to see every single time. In this case, you can see when the custom healing abutment was removed, the soft tissue contour is exactly how I expect it to be. And in order to support this, we did a custom impression coping. And the custom impression coping supports the tissue, and when then sent to the lab, that's exactly what they replicate. So therefore, there's no blanching and there's no adverse forces on the on the shield or on the soft tissue that I've created. Shade selection was done using conventional shade tabs and ELAB. And then the prosthetic was made that ensures that we have the same S-curve as described in the literature. This is the buccal view of that restoration in situ on the day of insertion. So this was the day that it went in. I didn't like the zenith, didn't look too healthy to me. The distal papilla was a little bit absent, and it wasn't something I was entirely happy with. But then when you look at that 1 year later, you can see that the tissue has healed, that zenith is now perfect, the distal papilla has filled in, and I can attribute that not only to the placement of the implant, but also that the contact point of where the lab has made this has been less than 5 millimeters to the crest of bone, as described by Tarnow. But I think that this is really only possible with partial extraction therapy, where we have not raised the flap and we have not had marked bone loss, and therefore we haven't had to go in and augment that later. So these are the results that I've come to expect, and I know that as I go forward with Megagen and I go forward placing only Megagen implants, this is exactly the results that I will expect to see going forward. And this is what it looks like 1 year later. So to me, partial extraction therapy is not only predictable, it's minimally invasive, there's no flap raised, the patients are happy with it, and at the end of the day, the dentist is also happy with it, because when you have a look at what you've got at the end of the day, it is biomimetic, it mimics nature. The soft tissue is good, having beautiful papilla infill and a natural contour is something that we all aim for, and I challenge any other modality to be able to do this as predictably as you can with partial extraction therapy. So essentially that brings me pretty much to the end, and I might have gone through that very, very quickly, but I'd like to give a big thanks to my mentors, and that's Dr. Howard Gluckman and Jonathan DeToy. I've always been able to reach out to these guys, and they are only too happy to share their information and to help me to grow my practice and to help me in my partial extraction therapy journey. If you like what you're seeing, feel free to give me a follow on Instagram and check out my cases, or you can reach out to me privately. I'm happy to answer any calls. I'd love to learn from you as well. There's so many very, very talented clinicians out here, and I think it's very, very important to be able to share the information as they do with MINEC. I think that's really, really amazing. It's something that I'd like to be part of. So from me and from Sydney, Australia, I really, really appreciate your time, and thank you very, very much.
Megamind.